So the last section we're going to talk about with complications of labor is the most difficult. Labor and delivery is the happiest place in the hospital until it's not, and then it can be really, really tragic. We're going to talk a little bit about fetal and neonatal loss in this section. The most common reasons for fetal loss are going to be preterm birth is probably the most common, but congenital anomalies and genetic disorders account for a large number of the rest. Maternal illness can cause fetal loss. There are several infections we've talked about through the course of prenatal care. So you know some of the things that increase that risk. When you're caring for a patient who is in labor with a baby that either will not survive or has already died, there are some decisions to be made and some things to discuss. If a poor outcome is anticipated, then the provider should be having conversations with the family about what their plans are and what their wishes are for the time around birth and the end of life care. One of the questions to look at is whether or not to do fetal monitoring. For a fetus that is not anticipated to survive, placing that fetal monitor may be triggering for the parents. They may like hearing the heartbeat, knowing that as part of their grieving, knowing that this is the time that their child is going to be alive and part of their time with the child. Or they may also be very devastated by the reminder that this child is alive now and will not likely survive. So fetal heart rate monitoring is not always used if the fetus is not expected to survive. Resuscitation is another piece of this, and this comes into play a lot of times in preterm labor. If a patient is in preterm labor and it becomes apparent they're going to deliver, if they're well past the age of viability, it's fairly easy. We're going to expect to resuscitate that fetus or that baby when they're born. If they are before the age of viability, then we're going to prepare the parents for comfort care, because resuscitation is not going to be realistic or beneficial. But there's a window in which we're not quite sure sometimes until the baby has delivered whether or not they are developed enough or big enough to actually resuscitate. To further complicate that, there have been some states that passed laws requiring resuscitation for babies born after a certain gestational age, and that those don't always allow for evaluation as to whether that resuscitation has a chance of being successful. But sometimes the decision about resuscitation has to be made after birth when the infant is being assessed. If that's the case, then a special care team should be present at the birth. Where should patients who are in labor or pregnant with a fetus that is not expected to survive, where should they be roomed? On a postpartum unit, they're going to see and hear other mothers and babies potentially. But if they're placed on a regular med-surg unit, first of all, they may not necessarily get the best postpartum care because those nurses don't necessarily know postpartum, but also they may feel as if everyone's trying to make them forget about the baby that they've lost. So different facilities come down different ways in that decision process. When a baby is delivered and is stillborn or is not expected to live, then it is possible, if the baby has a heartbeat, has breathing movements, then we can provide comfort care, just as we can for an older patient. If the baby has died, then at delivery, we would be preparing the body. Once the baby has passed, then it's nursing staff's responsibility to prepare the baby's body. We want to wash the baby if we can do that without causing damage. Now, if we have a fetal demise, if we have a baby that has died and has been a day or so, they may have a lot of maceration of the skin. And so we don't want to damage that skin further, we're probably just going to wrap the baby and add some baby powder to help with create a pleasant scent. But if the baby actually, if we're able to wash the baby and make them presentable for the family, we want to do that. State law determines when a fetus has to go to a funeral home. A lot of places it's like right at 20 weeks. Before 20 weeks, it's considered a miscarriage. After 20 weeks, they would have to go to a funeral home, but there are state laws about that. Autopsy and organ donation can be addressed with the family as appropriate, depending on the gestational age and the state of the body. And then we also want to assess what religious observances the family would like to have in that situation. Ideally, this family that's losing a child needs to be one-on-one care. We need to be there, be able to provide emotional and spiritual support while knowing when to give them space. We do encourage the family to name the baby, see the baby, hold the baby, because that allows them to begin the grieving process. Historically, people were discouraged from even seeing stillborn children with the idea that they'll just forget about it. People don't forget that. So we encourage them to name the baby, see the baby, hold the baby. Typically, they're going to be allowed to keep the baby in their room as long as they wish. If the infant's born alive but not expected to live, then typically they're allowed to keep the baby with them until they pass, and then we can do some preparation. They can spend some more time with the baby after that. If the baby is born alive or born with a heartbeat and breathing movements, we want to, ideally, we want to take a few photos of the baby for the family while they're living. We also need to refer them to support groups and for follow-up care, because this is a lot. This is a loss that frequently is kind of ignored, and they don't really get the support that they need. A lot of facilities have a memory box or some sort of organized program for this, but if not, the nurse can collect some things. We want to send some things with that family. We want to send some photos. Some families will actually have professional photographers come in and do a photo shoot, but we can usually do some photos if they don't have a photographer. We can do some photos in the nursing unit. A long time ago, when we used to have film cameras, we would do 1 or 2 Polaroids for them to take, and then we would take a roll of film. We take a roll, usually a short roll of film of the baby, and then send the roll with them when they're ready to have it developed. We can send blankets or clothing that were put on the baby. We can mark a measuring tape with the baby's measurements. We can do footprints and handprints. If the baby has hair, we can cut a lock of hair. We can give them the crib card and ID bracelet. So think about those things. I worked in a facility where they had seashells for infant baptisms, and they would, if the family wanted the infant baptized, they would have them baptized, and then the seashell would go with the family. Can a nurse do a baptism? That's going to depend on the religious beliefs of the family. In Catholic theology, if I'm not mistaken, this is the way it has been in the past, unless it's changed, you don't even have to be Catholic to do that baptism. Anyone can do that in an emergency situation. But obviously, if we have a chaplain or a pastor or priest of that family's faith available, we want to make sure we offer that. As a nurse, you're going to care for patients who are dying. You're going to lose patients. You're going to see heartbreak, and we hold those things for our patients. Make sure that you are getting care for your own grief. Okay. I will see you in class.